In this edition of the Nurse Executive Podcast, we have a frank discussion regarding the structural issues of bias in nursing. We will frame the conversation with the investigators of a recent national study regarding diversity, equity, and inclusivity in nursing practice. My guests are the study's researchers, Dr. Lisa Wolf and Dr. Anna Valdez, both PhD-prepared nurses and fellows in the Academy of Emergency Nursing. Dr. Wolf is the Director of Emergency Nursing Research at the Emergency Nurses Association. Dr. Valdez is Professor and Chair of Nursing at Sonoma State University. A quick note for our listeners before we get started. As mentioned in our inaugural episode, our goal is to keep these episodes around 20 to 25 minutes in length. The content in this episode, however, is so rich with information that cutting it down to that time length really would not do the topic justice. So we are presenting this episode in a longer format of 43 minutes. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Lisa and Anna, thank you so much for joining me today.
It's a pleasure to be here.
So tell us about your mixed method study regarding bias in nursing practice.
Anna approached the research team with a request to collaborate on a study about witnessed and experienced bias, specifically in emergency nurses. But this really reflects a lot of what's going on in nursing generally. So what we did was we took what's called a mixed methods approach. Even in the last couple of years, there's been a lot of surveys done by nursing organizations and national organizations, a lot of survey studies, which tell us about, whether people think racism is a problem. And of course it is. But what we did was we took our survey data and we used it to inform an interview guide and triangulated or further explored those survey questions with focus group discussion. And so that gives us a much more ground level personal view of what witness bias looks like, what experience bias looks like, how people respond to when they see or experience episodes of bias and what kinds, and also what their proposed solutions are to this really significant problem. And I think what we found was that people who identify as majority group people, right? So white people, cisgender, heterosexual, Christian people tend to score differently on the scores of microaggression experience and also ethnocultural empathy. They score differently than people who are in self-identified minority groups or marginalized groups or historically oppressed groups. So the experience of these two groups of people are very different. And that shows up in the survey data very clearly, and it is supported by our focus group data.
It was very helpful for us to do this as a mixed method study because we used validated instruments looking at the scale of ethnic empathy and microaggressions. Like being able to hear directly from nurses about their experience was very important. And our findings showed that all of the nurses really saw or experienced some forms of bias in their daily practice.
So whether that was lateral violence or bias directed at patients specifically, or at other providers, right? So it's not just nurse. Some of the nurses talked about specifically, they really focused in terms of like transgender providers and how those providers had a really difficult time getting the support of, trust from the nursing staff. A lot of nurses talked, especially nurses from racialized groups, talked about daily micro and macro aggressions from both patients and from their colleagues. And I think significantly for nursing leaders to understand, a compounding problem was not just the experience of racism or transphobia or homophobia, but it was the re-traumatization of these people who experienced this harm to get in trouble, like literally get called into the manager's office if they responded in any way to what was described as really like aggressive, flagrant abuse. And so there is a very significant group of our colleagues who are being harmed every day. And leadership has to be present to intervene immediately and to do some kind of restorative work. What came out in this study that was really not surprising, but has a huge impact on nursing as a profession is this lack of training on how to intervene in episodes of bias and also in how to address kind of the environment where racism or ableism or transphobia is permitted by patients onto nurses and nurses between each other.
Yeah, so let's talk a little bit more about that. One of the things about nurse executives is the need to set up structures for successful delivery of care and structures for healthy working environments as well. So, what type of underpinnings and structures are existing that may be contributing factors to these results that you're seeing?
I think part of it is that 80% of the nursing workforce is white. If you're in the majority group and are not harmed on a daily basis, you often don't see it. And that's, in fact, exactly what we saw in responses to the Journal of Emergency Nursing's DEI statement. The response to that was like, what are you talking about? There's no racism. There's no bias. Like, why are you accommodating or treating marginalized groups better or more than like we're all the same? So this is where we start. Evelyn Barbie, who is a medical anthropologist and a nurse out of Boston College, wrote two or three really fantastic papers. But what she described was the structures, the underlying assumptions of nursing as a profession that make it incredibly difficult to have a conversation about racism. And so she talks about how the first thing is that nursing is seen and taught as a dyadic relationship. In other words, you, the patient, and me, the nurse, we have a relationship and we do things and we move people along the path to health. But it's seen as a one-on-one interaction. So the structure, the environment in which that one-on-one interaction takes place is never discussed in general. Secondly, she talks about how there's this preference for homogeneity, right? In other words, we're all the same. We treat everybody the same. And I think a lot of nurses who are not racialized, who are not part of oppressed groups, really believe that we treat everybody the same, but we don't. And you can take a look at your metrics to look at that. I was just at a fantastic talk by Kamal Bajaj, who is the head of quality for the New York Health and Hospital Systems. And she is phenomenal. But what they did was they looked at their metrics in terms of quality and equity and access. So in other words, when you look at your, say, core measures, you say 70% of our patients in this hospital system have met the sepsis core measure. They got antibiotics within an hour, we got a lactic acid, we did all the things. What she suggests, and she said, we'll show you a very different picture, is if you break down your patient populations into distinct groups. So in other words, 70% aggregate may make the cut. But does that really mean that 90% of your white patients and 30% of your Black patients or 25% of your Hispanic patients meet that mark, right? To really break that data down to see who is getting care and who is being excluded from care is really important as a knowledge exercise, but also as a standards exercise, right? It can help you really identify areas where your systems are breaking down.
What's encouraging for me as I listen to you talk about this is that we have had organizations ask us to assess whether care is being provided differently to different patient groups in their organization based on a variety of factors. It's encouraging that some senior nurse executives are already asking these kinds of questions for the organizations they lead. Anna, you're the chair of the DEI committee for ENA. You've got now all this research that's coming out from the work that you and Lisa did together. What's your next steps here for this? And what should a nurse executive do with this information, knowing that, hey, we're potentially treating people differently, or we're not setting up the right structure for everyone to receive care?
I think that nurse executives are really in a key and critical role for making change towards health equity. The Future of Nursing report that came out this year, looking at charting a path to health equity, I think is really driving change now. We are going to see it with nursing schools, with accreditation changes. And we've already seen it with the Joint Commission with
Right.
new accreditation standards that'll be rolling out in January. And so I think that there's a lot of work to do first around awareness. We didn't need to do this study for ourselves. I knew that bias happens every day in the emergency department. I know that it happens in hospitals. We have a plethora of evidence showing health disparities in all types of different populations. There's tons of studies. But one of the problems that we face in nursing is bigotry. And so I think because it is not in line with the way in which we see ourselves as nurses, most of us went into nursing with the idea that we were going to serve other people, help other people. And so to look at ourselves and say we're biased or that we're racist or that we're harming patients just doesn't fit with that. And so I think a lot of times nurses focus on kind of the personal and interpersonal aspects like of racism, not the structural and institutional factors that are really causing a lot of harm. So I think nurse executives first need to really gain some awareness. They need to understand that racism and bias are extremely prevalent and that it is directly impacting nurse experiences, patients' experiences, and patient outcomes. Because without that level of understanding and awareness, I don't think they can effectively lead us towards a path to health equity. And one of the things that really stood out to me in the new standards is that the nurse executive, the hospital needs to appoint somebody who's going to be responsible for this health equity work. And so one thing I really want to say to nurse executives is you can't just put somebody into this position with no budget and no resources and no power and say, here, address this standard for us. There needs to be power and authority with that position. And CNOs really have to be in a place to support and lead and aid in that work. I think all too often we appoint somebody and it's okay, you're our DEI person, but you don't have any power or any budget, and we're going to check off this box. And so, with the work that I think is going to be ahead of us, really looking at how we deliver care and how it impacts people, and also nurse wellness, how we are treating our colleagues, I think that really understanding and doing some self learning and having an open mind and not thinking it doesn't happen here. We treat everybody the same here. It doesn't happen here. We're a good institution. We're good nurses. You have to move past that and begin to understand the structural determinants that are in place that support bias and then support disparities and inequities in care.
So, hearing about those new standards, what implications do you see at a strategy level for health systems? Because health systems make decisions on where they place hospitals, where they place ambulatory care centers, whether to keep a freestanding ED open or closed based on payer status. And in many cases, payer status is when you look at those that have Medicaid or no pay, there are associations there that go with minority populations. And so are the standards in any way affecting those types of decisions? Because at the end of the day, the hospitals also have to operate a business and make money to keep the doors open. How do those two things play together?
The risky answer is that healthcare shouldn't be a business in the way that it's set up. You've got to keep the lights on, but you can't. The minute you start saying we can't serve this population because they can't pay us, you have just introduced a major element of structural bias into that community, right? Because those are the people who show up at your mothership in the white neighborhood where everybody can pay and they're immediately dismissed because they're not white. They are a black or brown body in a white space, and that is immediately threatened or dismissed. And we heard this in our study, is that most of our patients are white. And so when Black patients show up, we're like, what? Basically, why are you here in this space? Oh, I guess you couldn't get care in your own neighborhood, so you came to ours, right? And that divides community. It perpetuates these biases that affect assessment and care trajectories and effort, right? Like all of those things that are subconscious algorithms that everybody runs. And doing what you're talking about and not putting adequate healthcare in neighborhoods that have people in them only further creates these huge chasms of healthcare.
And I would add that the standards are really about looking at the delivered care, no different than, say, we look at the care of people who have sepsis, right? It's looking at stratifying by groups and looking at health disparities within their own systems. And so what I would say to nurse leaders is, this is very important work for you. You want to understand how you are delivering care and that you are not harming people as an institution. And so I think that it really has to be about mindset, right? We know this is why there are so many health disparities, that people are not investing in historically marginalized and oppressed communities. We also know that hospitals that have higher amounts of historically oppressed people have lower reimbursement, and in fact, even get lower reimbursement based on the same kinds of issues. So I get that that's a concern. And certainly people could make a decision that they're not going to place their clinics, hospitals, or things in areas that historically oppressed people live there. But then I would say to everyone, what is driving you? We're healthcare providers. What is driving you? That you would decide to completely marginalize and not serve a population of people because you're not doing it well? Why would we not embrace that we need to do a better job? And so I think that doing this work could be really transformational for institutions and could really drive nurse satisfaction and therefore nurse retention, patient satisfaction, return to the hospital, those kind of things that are important from a business mindset. So I think it really depends on how you look at doing this work. The other thing is, my hope is, like many other core measures and standards, that this information will be publicly available so that people can go on and see how do people who have the non-dominant group, whether that's how they're racialized or their sexuality or their gender, how do they get treated and what are their outcomes in this institution? And I think nurse executives really have to look at that and say, it's not just people who are being historically marginalized or systematically oppressed who are going to choose not to come to our hospital because they know that they're not going to get good care. I think many other justice-minded people look at that and go, I'm not going to a hospital that doesn't treat other people as well as they treat me. And so I think that there's more to this than just the bottom line, that we really have to go back to the idea that we are tasked and have the responsibility of accompanying human beings in their care and meeting those needs. And first and foremost, we have to see everybody as human beings and as people deserving of equitable and quality, safe care.
Are there recent studies that are out there that are looking at, let's say, sepsis compliance on the sepsis bundle and breaking that out by race, or cardiac catheterization times? And
Yeah,
breaking that
there
out by-
actually are some studies around that. They actually center more around triage, emergency department triage, because that's where people fall into these core measures and bundles and stuff right off the bat. And there's actually a fairly substantive body of literature that suggests that case matched patients, Black patients with chest pain, end up being triaged down to ESI levels. So whereas white men, white men are triaged as 2s, Black men are triaged as 4s, and that creates a delay in care that puts those patients outside the PCTA window, like the ideal PCTA window.
Yeah.
Yeah. We see it a lot in children. There's Pumala and Zook and some other people. There's a bunch of people that I've been studying a lot lately around the under triage of specifically Native American children, Mexican American children. And I think this is partially where this comes from. If you are in the majority group, like you expect behaviors in the healthcare system to be somewhat congruent with what your understanding of, like, how do people act when they're in pain? How do people act when they don't feel well? And there's a large chunk of the American culture where the idea is that you sit and you wait your turn and you don't act out and you don't complain. And so people who come in with different behaviors are seen as threatening. There's some great stuff up online recently where nurses were talking about how grief, like the physicality of grief, was seen when exhibited by Black family members as really threatening. And like they would call security, as opposed to grief behaviors as exhibited by majority groups, which are maybe less physical, right?
Yeah.
So it's really about how do we interpret the behaviors of people who come into our hospitals that can influence how we interpret their symptoms. Does that make sense?
It does. So, Anna, I think you mentioned earlier, 80% of the nurses right now are white. And with you particularly being a chair and a professor of nursing, from an educator perspective, I'm thinking about the Robert Wood Johnson Foundation and how they try to intersect or look at the cross-pollination between policy, eh, practice, and education. And so what role because hospitals can only hire nurses that apply for positions. And so how do we shift and begin shifting the population of nurses to better reflect the patients that we're providing care for? What does that look like?
I think that's a great question. So we have been talking about the need to increase diversity in nursing since I was in nursing school 33 years ago. We know that when there's racial concordance, that health outcomes are better. We know that when there's diversity, not only do colleagues learn about culturally informed care, but patients get culturally informed care. Yet we've made very little progress in that 33 years that I've been involved in nursing. And in part, I think that's because in nursing, we tend to put up a sign that says, we welcome diversity. And then we're surprised when we don't have diversity. We said you were welcome, but people didn't come. But in fact, there are so many barriers, structural barriers that exist. For example, admission policies for nursing schools heavily weight, if not completely weight, on academic metrics. So GPA, entrance scores on various standardized tests. And those policies significantly advantage people who are already advantaged, who are highly resourced, who can pay for tutoring to be able to take those exams, who maybe don't have to work while they're in school. And so they're able to maintain a high GPA. So we continue to perpetuate the structural inequities that have always existed and then seem surprised that we're not increasing diversity. So I think in nursing, it's really well past time to be talking about what needs to happen. We know what needs to happen. We just have to make the commitment that we want to make that happen and we're going to make that happen. So it's really about action. So nursing schools, and this is work that I'm working on, need to change the way that they are admitting students using a holistic review admission criteria that looks also at attributes and experiences, and that those things are evenly weighted, and that we're looking for candidates that meet our mission and vision rather than just who's got the highest GPA, because that's not really a predictor of how good a nurse is going to be. The reason why we do that is because it keeps our NCLEX pass rates up and we graduate successful students. And we think that if we change that, that's not going to continue. So we are at the forefront in education of preventing diversity from happening. But then further, as students and diverse faculty enter our schools of nursing, they are unsupported. Oftentimes they experience racism, bias, other kinds of oppression within the school that make it very hard for them to progress and to be able to meet their full potential. we as nurses, nurse leaders, whether that's in academia or in practice or in policy, we need to do reflection about what we're doing and how our policies, our processes are set up to advantage dominant groups or normalized groups in our society and to disadvantage other people who are not part of that dominant group.
So let's take this conversation a step further because what I heard you say is, or where we started the conversation is a nurse executive can only hire people that are applying for the job. And if there's not enough nurses that are in minority populations, that's the first challenge. And then you talked a little bit about how do we potentially recruit minority students or people that can be successful. But the rate limiting step there actually is how schools get measured at the end of the day by their NCLEX scores. So shifting that to the third wheel, which is policy, is NCLEX pass rates really an appropriate measurement of nursing education? And if not, what?
That's a great question. Yeah,
That is such a great question. First of all, I don't believe that NCLEX is really a good indicator of the quality of a nurse, right? It's a standardized test. It is a large focus. But I want to just back up a little bit on that. And that is the idea that nurses have, particularly nurse educators, that somehow if we diversify our student population and we change the policies, that we're going to have to lower standards and we're going to have lower NCLEX pass rates. And really, that's a very kind of racist and biased ideology to make an assumption that because we have more diversity in our program, that now that means that our NCLEX rates will drop or that the performance will not be as high and we won't be as successful. So part of that is just examining our own views and policies around that. And I agree completely. I think that nursing education has to be transformed to really look at what are indicators of a safe and competent nurse, right? Are we resting all of this on a standardized test that some people can pass because they're very bright, but then they can't really even provide care? And then I think the other thing is you talked about we can only hire who applies, right? But one of the things I'd like nurse leaders to take away from this is that when people who are not part of those traditionally dominant groups are hired, they experience bias, aggression, harm on a daily basis. So in terms of retaining them in nurse wellness, we have to do the work of not just having diversity, but really of having equity and true inclusion when people are hired. Nurses in our study and the focus group overwhelmingly talked about the fact that they experience bias or they witness bias, but they don't report it the vast majority of the time because when they report it, nothing is done about it, or the opposite, as Lisa said, is that they get disciplined, right? So a patient is totally inappropriate with them. They say, you can't talk to me that way. And now the nurse is being disciplined. So it's a further kind of punishment and harm that is happening to people once they get into our systems. So nurse executives need to look at their structure. They need to have policies. How do we deal with when a patient is abusive and racist and harmful for nurses? Do we switch assignments? In which cases do we switch assignments? How do we deal with these complaints of bias and harm? So it's not just like a kind of suck it up. It's part of being nursing and you just have to take the abuse.
I would agree with everything that you say. And I think this is also a really good opportunity for nurse executives to start developing really strong clinical academic partnerships with not just the four-year universities, but the community colleges, which have much higher percentages of historically minoritized students. So if you want to increase diversity, like that's the place you want to go. And those community colleges turn out some really fantastic nurses. They are the attributes. There's some literature coming out on that as well. Like you've got a much more supportive environment for nurses from minority groups. They feel more belonging. They do better. And so those are, if you want to try to diversify your workforce, like that's the partnership that you want to make. And then support those students as you move them through whatever other educational path they need to or want to take. There's nothing wrong with bringing in a whole group of those folks, even if you want to have BSN nurses, help them get their BSNs, right? Be supportive, get them through that process. And that is a way to increase not just diversity in the pictures, but diversity of thought, diversity of understanding, cultural, um, a much more cultural concordance with your populations, with your patient populations, which also produces better outcomes. Like that, it's not just something that looks nice on a scorecard, like it actually improves your patient care.
Absolutely. Can I just add too, because I think this is a great point to introduce structural bias and policy. So, for example, we have embraced magnet status, right? And that's been embraced across the country. Many hospitals have either sought it or they're on a journey. But the way in which those policies have been set up, where primarily hospitals will only hire people with BSNs, that in turn creates a situation where there is a lack of diversity, with many of the students who are diverse being in community colleges like me. I would have never been able to go to college if there was not a community college based on my positionality. And so those entry steps allow people who have been historically oppressed and are better set up to support people who have been historically oppressed to enter nursing. But yet we've added new structures and policies and processes to further limit their ability to engage in the workforce. So I think, again, we have to look internally at who do the policies and the practices that we develop advantage and who do they harm? And be very thoughtful about how we are implementing these policies and how that serves our ultimate goal of achieving equity and the best possible outcomes for the people that we serve.
One of the hot topics right now in the workforce conversations is around recruitment and retention. I'm just wondering, what is the difference on retention rates among nurses that come out from traditional BSN programs versus community colleges that cater to populations?
I think it depends on where you are.
It does. It really depends on where you are and what the policies are for different institutions. I don't think that there are really good studies or data out there comparing like the retention of BSN grads versus ADN grads. But what we do have is really great data about the experiences of people who have been minoritized when they entered the workforce and as they continue in the workforce. So you could posit that with community colleges having more diverse nursing students, and graduating more diverse nurses, that those nurses experience harm. That's certainly found in our study, that nurses who are historically minoritized are experiencing daily harm. So whether or not that relates to overall retention or not, I don't have the data for, but I think we can all imagine and hypothesize if you are being harmed at work all of the time, that you're not going to want to stay there. But it's not just institutional. Where do I go? Because this is across the board in nursing, those experiences. So really, we have to fix the way and identify the way that we're treating people, the way that we're giving them assignments, the way in which we allow other people to behave in the way that they're communicating and interacting with people who have been historically marginalized. Frankly, I think if we increase diversity, if we fix these things where people are treated without bias and without harm, and the nursing workforce and academia is set up to support diverse learners and to promote success, then ultimately we'll have much better retention and we will have better nurse wellness and we'll have better patient outcomes because we're addressing those injustices that currently exist.
A lot of what Anna's talking about really fits in, is very much supported by our studies on bullying and on PTSD. We allow people to act in certain ways, right? And where this falls into is this narrative of suck it up. This is what nursing is. And we see this in people who suffer harm, not, just because, I don't know, they bring a weird lunch and also because maybe they are in a racialized group or a gender expression group that is not familiar to the rest of the workforce. There's all kinds of reasons why people are bullied. But the thing is that the process of bullying and the process of racism and ableism kind of overlap in a lot of ways, right? You need to have a dominant narrative that says this behavior is okay, that we're just toughening you up, we're just making you better. That narrative has to exist in some form. And there has to be somebody who perpetuates the harm. And we found in our study of bullying in emergency nursing, that person was the charge nurse who had the potential to give inappropriate assignments to people they didn't like and easy assignments to those that they did or whatever. So I think that having worked also in ICUs and in PACUs and in other areas of the hospital, charge nurses are really instrumental. Unit managers, who gets their vacation denied, who gets their vacation approved. There's loads of pain points where people can be treated differently. And so what we found in our study of bullying is that the only way to stop that behavior is to call it out. And what we found in our study is that a lot of people would not do that. They would not confront someone even if they saw them causing harm. For example, a nurse gets report from the oncoming nurse, they get the report from the offcoming nurse about like this patient, like, they're fine. They just want meds. They just want pain meds. And so the way in which report is given, the oncoming nurse reports feeling like, oh, they're treating this patient badly because of whatever attribute, fill in the blank. But that nurse, the oncoming nurse who recognizes the harm, never reports that to anyone. They just go in and they take their way of managing that is to treat the patient really well. But our question to them was, so why would you not report that? That's obviously a pattern, right? That's not just Sally being grumpy about this one patient. So when does it become a big enough pattern or problem to report that? In the same way that you would report someone who didn't do any vital signs or didn't do any wound care or didn't give any meds. It is a similar kind of harm that is being unaddressed. And so, however, when people confront those kinds of behaviors, then they stop. So that's a big part of it. And what we found in our study in terms of how people responded to witnessed bias was they stated right out, I would never confront that nurse. I would never because I don't know what their intent was, right? So again, we're back to this dyadic one-on-one management of what is essentially a much bigger problem. And so for the same reason, the participants in our study were like very resistant to the idea of structural solutions. There doesn't need to be a policy. There doesn't need to be any consequences. We'll just model good behavior and everybody will learn. If that were the case, this would not be a problem, but it is. And so the message for nurse executives is like, you got to take the bull by the horns here. Like you have to make a stand here and say this behavior, this is what we're looking at. This is the impact on patients. This is the impact on our colleagues, right? Our physician and nurse colleagues and all of our other colleagues. And we will not tolerate this. If this happens, here are your consequences.
Yeah. And I think importantly for nurse executives, the National Commission to Address Racism in Nursing did a survey asking about nurses' experiences with racism that really mirrors what we found in our study as well. 57% of the respondents said that they have reported racism that they witnessed or experienced. And when they did that, only 30% of the time, something happened as a result. So 65% of the time, there was absolutely no change, no interaction. And I think if you are being systematically marginalized, you're already being othered. Maybe you're one of one in the department, in your whatever classification, right? You're racialized as a non-white person. If you're already othered and you're already experiencing bias and harm on a daily basis, why would you share that again? Why would you bring that to management if you know nothing's going to happen and potentially you'll be punished? The other thing that's really important to note is in that survey by the National Commission to Address Racism in Nursing, one of the main actors for committing racism was supervisors and nurse leaders, right? So that is what nurses who were experiencing racism shared, that a lot of that time, the majority of that time, it is their coworkers, their supervisors, and their nurse managers. So nurse managers play a really critical role. Nurse executives play a really critical role of setting the tone and the expectations. When you set the tone that you cannot do this, we won't tolerate it in our institution, things will change. But as long as it is ignored or perpetuated by nurse leaders, we're not going to make the changes that need to happen.
What are the next steps for the two of you? You've done this study, and where do we go from here?
I would love for us to create a nurse executive, nurse leader toolkit with resources that are available, educational opportunities so that they know where to go to get those resources. But I will use this study to raise more awareness because we have to get past nurses thinking that this is not a problem, that it's not happening where they are, and to create education that addresses those areas that we've identified. And then I also think we make policy recommendations.
So several things came out of this study for me. The first is really Barbie's framework, which gave me a much richer, more critical lens, I think, with which to look at how nursing is taught and how we look at our patients, how we teach nurses patient presentations, right? So there's a whole bunch of stuff in there that I think makes it clearer to describe the ways in which we harm patients and how we can fix those things. The second thing is that in the same way that we need to weave things like trauma processing throughout all of our nursing education, understanding how do you apply the concepts that we've talked about here today to things like outcomes metrics and planning and education, right? How do you make sure that you are providing both care and education in ways that ensure access, that ensure inclusivity, that ensure equity? So I think there's definitely a clearer way forward for me.
Lisa and Anna, this has been a great discussion today. Thank you so much for your time and contributions to this important initiative.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.